Welcome to Real World NP's Clinical Pearls, where we take gems from full-length episodes and break them into quick, digestible insights. I'm Liz Rohr, family nurse practitioner, and my pronouns are they, she. Real World NP is a continuing education company for nurse practitioners in primary care, especially new nurse practitioners navigating the role transition from RN to NP. Whether you're on your commute between patients or prepping for an exam, these bite-sized takeaways can help you build confidence in your practice. Let's dive in.
That way you don't miss like osteoarthritis, but like in the back, in the posterior aspect. And then you can also get a merchant view. It's also called the sunrise view, and that's basically looking at the knee from the top and looking at the patellofemoral joint. And then you can right away like diagnose, well, not right away, but it can kind of like guide you into your potential diagnosis. If there's narrowing, how much narrowing there is, then if you have narrowing in that merchant or sunrise view, then maybe the patient has some sort of patellofemoral syndrome of some sort, especially if the patient says, I'm having pain walking down the stairs, and then you see a merchant or sunrise view that is narrowing, then that kind of like clicks. And then they could also have osteoarthritis of the medial joint line and the lateral joint line, but then you're also, depending on the symptoms and the history that you get, could be leaning more towards the one that is causing most of the symptoms, right? And then the last view is kind of like the lateral view, but that one doesn't give a lot of information. So if you don't have to get that one, you don't get that one, but definitely the weight bearing AP, that's essential. Like that one is essential. The merchant view, I definitely do recommend it in the weight bearing flex knee, the posterior anterior view. Those that one is also called the Rosenberg view, but those are kind of like the main ones. Otherwise, then you do miss the correct diagnoses.
Totally.
Right. So
totally. Do you ever get x-rays and then you can skip the MRI because you've gotten all of those images, or is it?
Absolutely.
Cool. That's good to know, because I feel like sometimes like and maybe this is just the healthcare system, but I feel like sometimes I see that where it's like, it's almost like you need an x-ray to buy you an MRI, right? Because the MRI doesn't get approved unless you have something first.
Yeah.
And so sometimes it feels like there's going to be an MRI done anyway. So I'm going to like let them do the right one. But that's really helpful. That's really great. That's really,
and when it comes to like imaging, a lot of the times you don't even need that MRI.
Yeah.
And I think that's why too, like they have implemented and put all these things into place.
Yeah.
Because unless you're completely incapable or unable to diagnose based on clinical symptoms, physical exam, and a plain x-ray, then really like there's no merit for that MRI. The MRI mainly looks at the soft tissue. So if you're trying to rule out like osteoarthritis or even a fracture, x-rays are the things to get. And MRI is more the clinical picture that I'm thinking when I want an MRI is 20 plus 30 plus year old who just engaged into trauma or had some sort of injury, right, like exercise related sport, and then he's complaining of instability of his knee, and then he has a big swelling knee, and I can't even do the instability testing, right, the maneuvers like to test for the ACL or MCL, because they're just so in so much pain. Then I do definitely want to get an MRI, so the MRI can look at the soft tissue and the ligaments, and then I can rule out or rule in an ACL tear, or even the medial lateral collateral ligament tears. So then that's why like that's like one of the reasons why I would go for that MRI before even thinking of the x-ray. But definitely, if you don't learn, if no one takes anything else except the imaging, go for the x-ray first.
And the right imaging. So
correct.
I have a question based on that. So like my experience of ortho so far is like in school, I think every school does their best effort to do as much as they can with the amount that we need to learn that time. I feel like the way that at least the takeaways that I've gotten from ortho is like, oh, it's just the structures that are in front of you. This is easy. Just do these special tests and you'll have your answer. Is that real? Because I feel like that's
I'm being like very candid in this interview. I just feel like, is that I don't know. Do you feel like you feel comfortable with the special test? Because I guess the context is that I work with a lot of new grads, and I think there's this expectation similar to ordering a lab test, being like, okay, here's this lab, here's your answer.
Mm-hmm.
For me, it feels like those special tests are difficult to learn, difficult to like feel the true differences, and like may or may not be related to the actual underlying. Like, I feel like your knowledge as a specialist NP is like so sophisticated that you can see the whole picture, and it's not a plug and play thing. Do you know what I mean? Like, does that make sense?
No. 100%. I 100%. But so here's the thing. I think the difference between, like, let's say orthopedics and other specialties, or even, as a family nurse practitioner, I also practice, right?
Yeah.
A little bit. And I also do work also like in the urgent clinic, like I was telling you earlier. But here's the thing. Orthopedics is very hands-on. So we don't depend so much so on labs, rather than on our touching and feeling and watching and seeing. And it's very, you need to develop this tactile sense, and also you depend a lot on the imaging. So you're not reading reports. As a matter of fact, when patients come in and they just have the little piece of paper, that's another pet peeve. Tell your patients to take the CD with the images.
Good. That's
when they go to the specialist. That's a big takeaway. Like, if you go to like an orthopedic surgeon and you take your little report from the radiology department that says that you have an impression and you have a list of a million things, that's not high yield. Like, the orthopedic surgeon wants to see what the knee looks like the intricacies, like what does it look like on imaging, because many times things either, I'm not gonna say they get missed, but like there's many things that you can think of when you correlate that clinically. And so in school, I just think that they threw at us so much, and it was like, oh, so comprehensive, I cannot do this. But there's a lot of high yield physical exams that you can do that are so easy. And I don't know if I say this because I have done this so much, but I'm gonna but I really think that nurse practitioners have the capacity. I promise you, you and everyone as a nurse practitioner has the capacity of doing the essentials. And the essentials can be as easy. And let me just walk you through like a physical exam for the knee. Now that we're talking about the knee, right?
Let's talk about knee. Let's do it.
So watch the patient walk. Like, do they have a limp? That will tell you a lot, right? And you don't have to have them run the catwalk or walk the catwalk. No, it could be just 5 feet, right? Like, and you can notice that. Like, is their gait ontologic? Do they have a Trendelenburg gait? So that's something that you can pick up in less than 2 seconds, right? You don't want to miss that. Visualize the knee, visualize the skin. That's another key thing. And I've had many patients come in with very tight clothing that they cannot lift their jeans or pants. And I'm like, no, I'm going to have to step out of the room and you're going to have to get on a gown. You have to do that. Like, if you're dealing with musculoskeletal things, you have to visualize the skin, because the last thing that you want to miss is redness or warmth or big swelling or a draining wound and pus. Like, you don't want to miss that because you didn't look under the hood, right?
Totally.
And so that is something that, like, let's say that if you're in primary care, you can kind of like prepare for the next day, and you see that the main complaint is kind of like that knee pain or hip pain or shoulder pain. Then I don't know if you have like clerks or MAs that can kind of like do the call and just say, hey, just make sure you're coming for this musculoskeletal complaint, bring comfortable clothing, or clothing that can be removed really quickly, so that the clinician can visualize and look at the skin and do a thorough assessment. So that is another key. And then you don't really have to do that when you have the patient in front of you and you're dealing with diabetes, right? Or hypertension.
Right.
But these are like little nuggets of wisdom that you want to think about when you're dealing with musculoskeletal care.
Totally. I was gonna say, like, every single time I have a knee pain, they're always wearing tight jeans. Like, every like, oh man.
And then you can see it. And then something that I've seen a lot, like, you ask the patient, okay, so have you had any surgeries in the past? Oh, no surgeries. And then I'm looking at the knee and I'm like, what is this big scar? Oh.
Enjoyed this clinical pearl? There's even more valuable insight in the full episode. Click the link in the description to hear the complete discussion, packed with practical tips to strengthen your skills and confidence as a nurse practitioner. Don't miss it. And if you found this helpful, be sure to like, subscribe, and share with your fellow NPs so we can keep learning together.